Recording in progress. All right, good afternoon, everyone, and welcome to the second webinar in our web series. This one is titled Substance Use and Substance Use Disorder, a Harm Reduction Approach. My name is Elizabeth Gonzalez. I'm the Associate Director of Birth Equity here at EverThrive, Illinois. And today again, our topic is on substance use and substance use disorder, highlighting harm reduction approaches. And our guest speaker today is Dr. Ruchi Fitzgerald from Rush University Medical Center. Next slide, Haley. Thank you. And then just for folks that are not too familiar with EverThrive, just wanted to highlight some of our mission, our visions, and our values. So for more than 30 years, EverThrive Illinois has been advancing the health and safety of Illinoisans by supporting access to quality healthcare and providing resources to achieve health equity. Our aim is to affirm and center the experiences and voices of communities most impacted by injustice, to achieve reproductive justice for all people and families, especially those in Black, Brown, Indigenous, and LGBTQIA communities. We ensure they have access, resources, and healthcare necessary to create and sustain healthy families on their own terms. Next slide. And just a few housekeeping. If you can all just please keep yourself muted to reduce background noise. A follow-up email with all the materials and resources shared will be sent to everyone who registered. And please feel free to type questions in the chat box as we go. We will have a Q&A session at the end after the presentation that we'll be able to ask Dr. Fitzgerald all our questions. But please type them in the chat as they come up. All right, we'll just a quick agenda. We'll get started with some introductions, introducing Dr. Fitzgerald. We'll have the presentation, the Q&A session, and we'll wrap up with some resource sharing and next steps. So Dr. Ruchi Fitzgerald is an assistant professor in the Department of Family Medicine and Psychiatry and Behavioral Sciences at Rush University. She is also the associate program director of the Rush University Addiction Medicine Fellowship. She is the service chief of inpatient addiction medicine at PCC Community Wellness Center, a federally qualified health center system that serves the west side of Chicago. Dr. Fitzgerald is a National Academy of Medicine James C. Puffer / American Board of Family Medicine Fellow. Dr. Fitzgerald's work has focused on promoting cross-sector collaboration to improve care for persons affected by substance use disorders, with an emphasis in the perinatal / child health arena. Her scholarly work has focused on addressing stigma, building capacity in primary care for treating opioid use disorder in special populations, and implementing evidence-based substance use disorder curricula in the next generation of clinicians. Dr. Fitzgerald received her MD from the University of Michigan Medical School and completed her family medicine training with a Montana Family Medicine residency and her addiction medicine fellowship with Rush University. So welcome, Dr. Ruchi Fitzgerald. We'll go ahead and turn it over to you. And again, thank you for being here with us.
Thank you so much. And it's a pleasure to be here with all of you. So I'm just really delighted. Feel free to drop any questions in the chat. I probably won't look at the chat just as I'm going through, but I will leave ample time for Q&A and just hopefully just a dialogue. And again, I'm just really happy to be here. So the title of this webinar is Substance Use and Substance Use Disorder in Birthing People, Harm Reduction Approach. I am faculty at Rush. However, my clinical work and a lot of my policy work is done over at PCC Community Wellness Center, which is a federally qualified healthcare center on the west side of Chicago. And if we can just go ahead and go over to the next slide, that would be great. This is a beautiful piece of artwork by an artist, Nani Chacon, that I had really come across a few years ago. And as we can see here in the quotation, says, "I am more than my addiction, fighting for those I love and fighting for my life." There's really just no better time to really just take a moment and reflect upon this, especially as we think about the statistics that people are, our nation is facing as we read the news and read our journals regarding maternal mortality and drug overdoses and suicides, and how this can really be preventable especially in those overlooked communities and populations that we are service providers in, and how we actually are interfacing with individuals, and especially if those individuals happen to be, if they're patients, our friends, or our loved ones, and how are we looking at our these individuals simply as the illnesses that they are, at them as a whole person, and just remembering that people are people and humans are humans, and we are all here to support each other. This is such a beautiful piece of artwork. The thorns in this artwork really represent incarceration, as so many mothers who have been affected by substance use are at risk for interactions with the criminal justice system. This came out of Bold Futures in New Mexico, which is an organization that has done tremendous work on combating stigma, supporting mothers affected by substance use. And I'm just so grateful for this organization and learning from them. I'm including a quote from a patient that I cared for that really taught me so much. "I went in to get help. I wanted to stop using. I didn't know that they would take my baby away from me. I was born to a mom who was addicted, and I never wanted to end up like this." And, this was a really just important, learning lesson for our whole team, is that, when people come in to get help, and this situation ends up happening, it is a missed opportunity on the part of so many systems, and how those systems, they're not broken systems. They're actually designed to do exactly what they were intended to do, from an oppressive point of view, if we take a closer look. But I'm here to just kind of share a little bit about how we can support in some better ways, especially for those in these overlooked communities. Next slide. So just to kind of review some data that I'm always surprised that people are not aware of what's taking place in our state and across the nation. So drug overdose is actually the #1 cause of pregnancy-associated death in the state of Illinois and many other states. And for this reason, it takes really an all hands on deck approach to change this narrative and change what's taking place. One of the most important things is to look at when this takes place. It's often postpartum. So in that, like what we call the 4th trimester. And the reason that we kind of want to just break down some of this data is that, we've seen that, 32% in the past few years of these pregnancy-related deaths were actually preventable causes related to substance use or other mental health conditions. And then when we look at this, is really due to fentanyl or sometimes stimulants. And these are really like preventable causes. Often these people had maybe been in some treatment or dropped out of treatment after they delivered their infant. And this particular study that was published in the Journal of the American Medical Association had showed that, this relative increase was over the period of 2017 to 2020, relative increase of 81%, which is, of course, is astonishing. And just kind of coinciding with, looking at the COVID pandemic and multiple other factors, but also with the potency of illicitly manufactured fentanyl. All of this combined together is what I would really say is that we cannot continue to have a punitive approach to this population, which has really been the approach to people who use drugs for so long. But that harm reduction, which is just, you know, kind of a new concept for many people, and typically has not applied to the birthing population. So I'll just say that again, harm reduction has not applied to the birthing population, apart from maybe the provision of something called naloxone, which is Narcan, which is the overdose reversal medication. But it's really probably a new approach that's really needed in this field by all service providers, not just medical and not just you know, a social worker, but really is probably what's needed to kind of reverse this trend. Let's go ahead and just move to the next slide. So I think it's nice to just kind of maybe paint a picture with a few examples, and this might be a great opportunity for like some dialogue in the chat where we can talk about afterwards. So you know, I think substance use and substance use disorder come in different flavors, different degrees of severity, and certainly where I practice is in medically underserved populations, and people are often living in poverty. We're very fortunate, like extremely fortunate, that we actually have a program that's designated for individuals to receive substance use disorder treatment services for like all populations, but also a carve out really for pregnant persons, pregnant and postpartum persons. And that's funded by the state of Illinois, the Department of Human Services. It has a really well-rounded staff with, you know, physicians who are trained as obstetric providers, addiction medicine specialists, and also has like a peer recovery coach who's trained as a doula specifically, and then also social worker and a nurse. It's a really unusual model. We're very fortunate to have it as existing as like an outpatient program, not just like a residential treatment program. And so because of this model that we've kind of word of mouth has shared, you know, that we do exist and that we're very like low barrier, like kind of an open access, we have managed to see a lot of patients who might not otherwise seek services, you know, for healthcare and for substance use. So I'm just going to share a couple of de-identified examples. So this is one that's really de-identified. I've changed a lot of the characteristics just in the interest of protecting confidentiality. And so some of these examples that we'll go through are kind of grouped to some characteristics to kind of share just some of the real issues that people across Illinois do face, and try to share, you know, just kind of what we're facing, and just also like how we can use harm reduction as a way to really help these individuals and really put their needs first. So one of the first patients, so, you know, came to us in their first trimester and had a history, you know, pretty long history since the age of 16 of using fentanyl through their veins, like through a needle. And that is, you know, technically, you know, a special population as identified by SAMHSA, which is our federal agency, is people who use drugs through a needle are at high risk of, you know, high risk of overdose, high risk of infections. So we want to really, you know, prioritize this population, especially then they're also pregnant. So again, characterizing them as a very high risk population. So this person was also, you know, really at risk because they were not housed in a stable way, living from like motel to motel with other people who were also, you know, using actively. However, a big motivation for coming in was that this person was actually very excited about being pregnant and felt that that was a real window of opportunity for changing their lifestyle. One of the complicating factors was that from that injection drug use was a medical complication of having open wounds. So that was something that was very important to them to have addressed and to receive care. And they were, you know, fairly embarrassed about these too. So that's something that's important to recognize. They don't always, you know, share those at the first visit. And those really all are, despite being open wounds, you know, preferred place to continue to use drugs. So that's kind of, you know, the case presentation. And that's where, you know, I think having a provider who's medical, who has some expertise in this is really helpful. So, what is their approach? In many places, people feel completely overwhelmed of like where to begin. And I would just say that, for us, our approach is really like, what is important to the patient? And, what could we do to really reduce the harms from active substance use for this individual? So that's what we're really focused on, in addition to providing, some prenatal care. And also, addressing psychiatric care. And it turned out that that had been neglected for a period of time and really coincided with why there was so much active substance use in this individual's life since the age of 16. So a lot of post-traumatic stress, etc., and really just untreated psychiatric illness. And what we try to do is really create a culture of safety and an open door for care at our institution, at PCC, in the community. And I think because of our welcoming staff, and that's really been successful. And also by having a team of people, with our peer support, who are people with lived experience, who've, been in that patient's shoes, maybe not those patients' shoes specifically, but walked in a path of recovery themselves. That's really helpful and can be like, just someone who can guide them on their journey as well. One of the other pieces of our program is the explanation of what our patients' rights, and that includes an explanation, really on their level of the legal system, including like the clinic policies centering around drug testing, like urine drug testing, reporting to child welfare, and then also, reporting like what clinic records go where at the time of delivery. All of those things are really important, especially for people who may be at risk of being reported to child welfare and at risk of what we call family separation. And we found that being open and honest with individuals and explaining like, I am a mandated reporter, this is what Illinois law is, when are the opportunities for treatment and what might assist one in, in their recovery process are really helpful, because we'll just go back to that first quote of, the patient who had said, I went in to get help. I wanted to stop using. I didn't know that they would take my baby away. That has really informed us in how we care for people and a family together. And so, this individual, really was not fully successful in their desire in for a number of reasons, mostly due to there are other factors going on in their life, and they weren't really, able to achieve, full remission from substances in their pregnancy, which was not, in any way surprising. So, it would be, someone like saying to someone who had been using since like the age of 16 that you have, 7 months to suddenly stop, despite medical treatment. And I think that's really unrealistic because it takes time. Recovery is a process. And that's a really, really unfair kind of a timeline to place upon someone while they're pregnant, and pregnancy is very difficult. And so for other populations, we really applaud, you've had, you have severe alcohol use disorder. You've managed to reduce your number of drinks from, 16 drinks or 12 drinks a day down to 3. And I applaud you, and that's wonderful. Well, it's not the same for birthing people. You're expected to become abstinent in your pregnancy. That if you don't, you're going to be reported to the authorities. And so it's quite difficult. So what ended up happening for this individual was, of course, the mandated report, and that resulted in really a mandate for treatment. And I say that in the sense of that it was a mandate unless they wanted to have their child removed. And I would just leave everyone with this question: is like, does mandated treatment, is it a motivator, or is it coercive? And so it's just going to be an open-ended question for all of you, because for some, I think that it does work, and for some it may not. And I think it really depends on where someone is in the recovery process. And so I would just leave that with all of you. And we still continue to focus on a harm reduction approach that's patient-centered, in order to really serve the best interests of our patients. Can we go to the next slide? Okay, I'm gonna go ahead and talk about another patient, just to kind of illustrate some more examples of why harm reduction is so important. And really with the sense of that, I'm well aware of maternal deaths from drug overdose, and also of what some other factors are going on, especially within our emerging drug supply and how severe things are. So this is another individual who came to suddenly just, one mid-afternoon to just walked in, or actually called first and said they'd like to get help, and was halfway through her pregnancy, and also had a history of using heroin and fentanyl through a needle, and since a teenager, and I think that for those of you who work with youth, that's really, really informative, right? Because we think about like prevention measures and what might be implemented earlier in communities, and what, how do adolescents start using, and what leads them, and had a chance to sit down with this individual and learn a little bit more about, what was taking place in childhood, what childhood trauma took place, were siblings using in the home. It was very informative for me. This person also had some very significant open wounds, and some of the worst I'd seen actually in pregnancy, and was very concerned about their overall well-being, and also came with a very high risk of incarceration. And so, on kind of a mid-late afternoon, and it was fairly overwhelming for our team to interact with this person, with so many different issues taking place, all while with, in their mid-pregnancy. And it seemed, really like, when you're pregnant, it seems one should be really receiving much, much care as possible. And yet this individual was facing so many different issues, and it felt very sad, I think, for many of our team members, especially for those who are in recovery themselves. This person had shared that they had previously been incarcerated for a period of time, and upon discharge had been able to be successful in being sober for a period of time, had shared some of their challenges with the criminal justice system and some of the punitive things they had experienced. And just it was very informative to our team. So, as we prioritized what was important for the health and safety and well-being of, developing child and this individual, really involved just, immediate admission to the hospital for stabilization of substance use. And that was a very clear decision, right? So for all of us and for the patients that, we're so glad you're here. We'd like to bring you in and to the hospital and make you comfortable, and start you on medication, because the scientific evidence shows that when we start you on medication for your substance use, that's a life-saving intervention for both you and your developing baby. And just by simply stating that, the patient was very amenable to being admitted and being cared for. And I think that it just went very, very well. And then we were able to really meet them where they were at and discuss, the wound care and interventions for harm reduction. And then, as they stayed in the hospital for a few days, to address as much as we could, advocacy around some of their criminal legal issues, referring them to an organization that specifically deals with that, any advocacy with their probation officer, and also having, just an open discussion again, about the child welfare piece. They had prior involvement with child welfare, getting some emergency contacts, in case the patient did not follow up with us. and then also including, their partner, who was also having active substance use, about offering treatment in a compassionate way. So just some comments here is that, something about policies, and I do a lot of work on policy. So policy is not always just a law, but it's also very much at the core of what, we do as service providers. We almost always have a policy in what we can and cannot do and how we interact with others. And I would say that, as physicians or clinicians, we must know what our policies are, right? And we're birthing people. As treatment providers, we must know very clearly what these policies are and how they affect birthing people, because we are a very small part of their lives. I can guarantee you, most of the time, my patients do not think about me, but I have the ability to greatly impact them for the better or for the worse, based on my actions and my policies. And so in order to care for them in genuine partnership, must know these policies. And in addition, understanding Illinois law and federal law is really important. And I would say that not enough clinicians really know that. For this and all of our patients, I think the severity of their substance use really determines what strategies we use for medical treatment and psychiatric treatment, all of that kind of treatment, and understanding which level of care is what we would recommend for an individual. So essentially that really means like not everybody needs to go into a 28-day program, especially if they've done it before 2 to 3 times. For many of them, outpatient treatment or intensive outpatient treatment may be great and may allow them to, continue to work or, just organize other things prior to delivery, etc. Find housing, that's a huge one. And then just lastly, I will say, like, having an open door policy, like not requiring someone to wait for appointments, especially for prenatal care and for substance use treatment, is very important. And it's a model that I really promote. And it just allows for welcoming patients and promotes that engagement. So even if they can't necessarily see a clinician or a physician, if they can see the nurse or the social worker or the doula, and especially that nurse model where they are meeting like the peer and the nurse, or the peer and the social worker, and then getting the physician on the phone, that's a great model. And I think that just shows like, hey, we really care about you. You walked in, we're not turning you away. Let's go to the next slide. Okay, this is the last example that I have, and this one's a little bit longer, but I think that it's just is one that's important to walk through, because I think shows just sort of the complexity of the kinds of people we care for, and in terms of like the health problems that they may have and may be experiencing, but yet sort of the healthcare system's response. And we're all accountable, right? We're all accountable for what happens in our society. So this was a mother who came in, and she has elementary age child, and she reported that that her son was in kinship temporary custody. And so for those of you who are not familiar with that term, it essentially means that another family member is now taking care of that child instead of her, based on a determination by the child welfare system. And she came in after and she was in her late second trimester, so fairly late to prenatal care, and also reported that she has breast cancer at stage 2 that had not been fully treated. And this is all, on another regular clinic day, and was also wanting to be treated for opioid use disorder, had a history of injection drug use, had stopped for a period of time and had resumed because she was completely overwhelmed and saddened that she had been separated from her elementary age son, and had said that she had learned she had breast cancer early in her pregnancy and had been referred to a tertiary level care center where she had shared, I really would like to get help. And then had been set up for some follow-up and then went home and a couple days later, social services had came to our house and said, well, I heard that you have a substance use issue and I would like to investigate you for this. And so that just caused her to spiral into a very deep depression and caused her to really disengage and not trust healthcare whatsoever, which is understandable and led to more family separation from her son. And it's just and finally, you know, of course, as she became more and more pregnant, and some more outreach calls came from our health system. The patient did return and was very afraid and was a very timid individual. So, you know, what was our approach? And this is a really complicated situation. You know, someone who has breast cancer in pregnancy, they're actively injecting and has a very complicated child welfare case going on that they're very determined to resolve. So, you know, again, prioritizing like what's really important in order for this patient to really meet their goals. And that was really, again, you know, like, you know, would it be possible? Would you be willing to come into the hospital so we can stabilize you, and explaining to them, you know, that we have a scientific evidence that this medication can help you. It can really reduce the chance of dying from this disease and really help you, you know, reduce or stop using during your pregnancy and help you get in for your cancer treatment. And we'd love to also refer you to an agency that can help you with your child welfare case as much as we can. And that's really the core of this, what we call this perinatal harm reduction. It's like, what is every measure we can do to reduce the harms of the substance use? And that includes that medical treatment, talking about making sure that you don't use while you're by yourself. Do you have needles that are clean? You know, can we talk a little bit about switching from needles to using through your nose if you do return to use? Having those practical conversations that could be potentially life-saving in this kind of a situation. And for this situation, we wanted to really address this child welfare case, recognizing that family separation and the emotional damage, it can be very harmful for someone who's going through pregnancy and going through so much. So, you know, I think that this is such a helpful case to walk through with all of you. And also like this, the advocacy that is needed, that takes really hours, really like from a dedicated team. And also like this, the necessary knowledge that's needed for like an adequate dose of medication. And again, just understanding the outreach. If you don't hear from someone, to continue to outreach them quite aggressively, really, and have that open door policy, and to just recognize that, you know, this is a long haul. This is not like a short-term process. Like pregnancy is long, postpartum period's long. And if someone is actively involved in child welfare, like that's a very long process. It can take years for a case to be resolved. And we want to partner with our families and our patients for the long term. Let's go ahead and go to the next slide. So one of the things that we took on as a project that I'm really proud about is that one of our peer doulas showed me a toolkit from the state of New York, and it was also done nationally. But the Academy of Perinatal Harm Reduction and the National Harm Reduction Coalition had created a perinatal harm reduction toolkit, and we'll include this in the resources. But we had some grant funds through our program. And decided to make one for the state of Illinois that focuses on resources that are just really state specific for perinatal harm reduction. So the state specific resources really relate to like, where would you go for treatment, you know, like in Illinois if you're pregnant. So like that would include like residential treatment, for example, at Haymarket centers, or like how do you get sign up for SNAP, just different kinds of things. Or like, you know, maybe you're undecided about your pregnancy and you're considering termination. Like, how do you find out where to go depending on where you're living? Or maybe you want to navigate to PCC. Here's the phone number, like, or what's a peer doula? But it also is very practical. It's like also talks a little bit about like child welfare investigations And it also talks about, for substance use specifically, goes through like all of the different substances, alcohol, nicotine, stimulants, opioids, and practical ways to reduce your use. So it just goes so far beyond just like having naloxone, but it does have also like a page about like how to reverse an opioid overdose in pregnancy. It's very comprehensive. It even has a section on xylazine. It's really just, oh, and just in the chat, I did see that pop up. It's going to be included in the resources and emailed out to everyone who signed up for the webinar. Like, it's downloadable. And it does include a section on stimulants. And it's just, I learned so much from reading that toolkit that I felt it was very important to make one for Illinois with, and the most important part of this is that the authors of it are people with lived experience, plus medical providers like nurses. And that's why I think it's so, it's been so well received. And plus it has this public health aspect. I will say that if you approach service provider, patients as service providers, and you just say, I would like you to stop using, it's very unlikely that that will be the result. So this really has a framework and an approach that is more likely to be successful because it's a harm reduction framework. So just remembering that harm reduction is like any positive change and really a practical approach, especially when people have been using for a long time and then become pregnant, like they weren't necessarily planning to become pregnant. This is really helpful. It also is like an important framework for respect, for unconditional positive regard. For those of you who work as psychologists or social workers and might be familiar with that framework. Before I became an addiction medicine fellow, I'd never heard of that. I never heard of that because, you know, really like the tendency is to stigmatize drug users. In addition, especially for pregnant people and postpartum people or parents who use, it's actually like discrimination and often like really hatred towards them. But this pulls us back and shows that like when we use that approach of unconditional positive regard for people, regardless of where they are in their lives, like we actually can have much more engagement. And our goal is really to have prenatal care and have engagement and really include people regardless of where they are, because we all have the same goal in mind, like a healthy birth and a healthy mom. And where we are right now with our statistics is really abysmal and unacceptable. Would it be okay to move to the next slide, please? Thank you. So this is just an example of like what is a perinatal harm reduction plan. And it's really been a journey to work on this. And it's like an emotional journey and just like a really learning process for me as well. So, you know, we start out with like the basics, right? Like just having Narcan in the clinic. Then we move to like having fentanyl test strips, moving to having like information about xylazine and stimulants and co-use of substances. Now we have xylazine test strips too. We have like all team members trained on how to talk about this, and you know, really like just people can go home with a bag and have access to this. And people ask for it. They'll ask for a couple of Narcan, sometimes 3. They'll get refills on it when they come. We actually then now have a harm reduction truck from Live for Lolly, which is a well-respected harm reduction organization that comes on site to hospital property like once a week, which is really incredible. Like, it's very rare to have a harm reduction like mobile truck come on site to hospital property rather than just, you know, like a community site And that's really, really important that then people can go, and if they are actively using it, that's for all of our patients, not just for birthing people, and they need clean supplies, because as a federally qualified healthcare center, we would not be able to give them, clean supplies. We have an open-ended conversation about not using alone, right? So like we give them the Never Use Alone hotline number. We have a flyer. We post in our clinic. We give it to them. We talk about that because if you're using alone, you're at risk for having an overdose alone and dying alone. So that's another one. Another one is that MAR Now. So like there's the state hotline for accessing buprenorphine or just accessing like methadone. So that would be another option if like people run out or you're in a rural area. But also like for us, if they're accessing our clinic, it would just be like, okay, so you had a return to use, you haven't been in for a while. Do you want to come in like right now? Or do you want to come in tomorrow? Or you want to come in on Monday? So it's just like, how can we facilitate that and like work with your insurance to get you transportation? Or do you need bus cards? And then also having that doula or peer advocacy. We do a lot of like just coaching, like coaching the patient on success, like tips for success, like how to take your medication, having your items organized, what do you need to organize at home before you come in. We've always found that like coaching people on simple things can improve their success and retention. I do talk to people a lot about switching from needle to nose. There have been some other movements in the harm reduction community about some other strategies. Definitely talk about clean supplies, clean water, getting tested for infectious disease, and that would include STI testing. We also screen for trafficking. We have, it's not just a screener, it's a conversation, trauma responsive care. We talk about prenatal care. We talk about substance use coercion. We talk about nicotine and alcohol in pregnancy. These are all components of our perinatal harm reduction plan. We love having peer doulas. We've had a number of peer doulas that have had tremendous impact on our program, and it's a luxury to have these individuals. They are very rewarding staff of our program, and we value them greatly. So these are either peers with lived experience, or maybe they've had family members with lived experience who are then cross-trained as doulas. We have had some doulas who we've cross-trained as peers. And that's just like a really valuable part of our program. And they're just like an advocate for the patient. So they're non-medical, and that's a really unique role that they can play in just really encouraging that patient engagement, but also, and they really like actually tackle some of those social determinants of health. In ways that like, when you don't have systems in place that really can do it. So they're very creative oftentimes. And they also can like sometimes get into the issues of intimate partner violence and identify and flag those for us. And also like if a partner needs treatment, also advocating for housing support and food insecurity. So we've seen some real value in some of these things. When we have those community agencies and doula support. And like I mentioned before, knowing your rights, that's all part of perinatal harm reduction, preparing patients who may be at risk for that DCFS investigation. And then again, like talking about, I actually haven't mentioned this yet, but breast and chest feeding and postpartum contraception ahead of time. And also like talking about eat, sleep, console, neonatal withdrawal. We've talked about all of these things as part of our perinatal harm reduction. This is all in the toolkit too, so this is just some high points. Okay, next slide. It's just a quote that the most important and radical part of harm reduction is to demonstrate with our words and actions that we respect and love people who use drugs. I don't think that that's the same as endorsing it in any way. So I want to say that we don't try to endorse drug use. We don't romanticize it. We really try to say that we have a welcoming and open environment for healthcare. And we try to really provide education on the negative effects, but in a respectful way as well. Okay, next slide. I'm just going to walk through a few more slides about policies. Can you just advance a little bit more? This is a great website, and it just really shows that, you know, about half of the states consider substance use during pregnancy to be child abuse. 3 consider it to be grounds for civil commitment. Half of the states also require healthcare professionals to report suspected prenatal drug use to child welfare. There's some states that require testing. In Illinois, if you have basically like the infant has a positive toxicology at birth for a non-prescribed controlled substance, so buprenorphine and methadone are not part of those, then that will be a mandate report to DCFS, and DCFS at this point in time does have to actually send that file over to the state's attorney. That's technically law enforcement. I will just say that the House Bill 1464, that pregnant detainees shall not be required to deliver a child while in custody, absent a finding by the court that continued pretrial custody is so necessary to protect the public. So that is actually a good protection for our patients, though we do find that many of our patients do come. Pregnant people are referred out of incarceration, which is interesting. They are not held typically for long periods of time, but they are actually incarcerated while they're pregnant. Next slide. So I'm just going to talk briefly about a piece of legislation that we are actively working on with a broad group of professional societies and stakeholders to advance. I'm working on this for a very long time. And it has to do with something called family recovery plans, which I do think are really important. And they're just to get us to do what really the federal government has asked us to do for a long time, and is to have really like a comprehensive plan for the infant and the caregiver, the parent, the infant substance exposed at birth. So right now, actually, the Senate bill has passed and the House bill is going to be heard in committee on April 30th. The biggest thing that it does 2 big things. Like, number one, it would create a task force to kind of decide like what this model would actually look like to create a family recovery plan. And the second thing it does is that it would actually, at this point in time, repeal the mandate to take all those positive toxicologies and send them to the state's attorney, which is state's attorney right now is not happy about that, but we did pass out of the Senate, so we're still hopeful. And I just view it really as a public health bill, and the push for it is because right now maternal mortality rates are so abysmal. We really need a different approach. I will say that I think it's interesting to see, you know, who's leading this bill. This is right now, main push for it is coming from the Illinois State Medical Society. So that's Physician Society. It's also very much supported by the Cook County Office of the Public Guardians. Those are the guardian ad litems for, you know, the children involved who are, you know, at risk of child removal. So I just want to share that briefly, but I'm actually going to have you move to the next slide. And this is the closing slide. So I would just say that I never really thought I'd get really deep into this space in my career, but without really examining our state statutes and fixing these punitive policies, the ones that say that having addiction in pregnancy is actually like child abuse or child neglect, and looking at the justice system, I mean, birthing people won't come in for help. They just won't. They'll continue to hide in the shadows and avoid the healthcare system. So I am going to close with that and just open it up for questions. So yeah, here's my contact information. Great.
Dr. Fitzgerald, we do have one question. So yeah, the toolkit will be shared with everyone in the follow-up email. But Mary put in a comment that in downstate Southern Illinois, the predominant drug we are seeing used during the perinatal period is meth. Without medication, treatment options are, without medication, treatment options are you seeing this as well? Working in mother baby unit, it is immediate DCFS call. Investigator comes in hours after birth and takes baby into protective custody. Heartbreaking. And then
Yeah, so we do see a lot of stimulant related. It's not as much methamphetamine in city of Chicago, though it is certainly the case all over the United States and many states. Definitely methamphetamine. And where I did my training in Montana and practiced for many years, methamphetamine was certainly very much, a predominant substance, and especially for birthing people and for people who are Indigenous. That's been a substance that's affected many Indigenous persons. And you're correct, there are not a lot of evidence-based modalities, particularly for people who are pregnant, though many of them have co-occurring psychiatric or mental health conditions that are untreated or undertreated that could be treated. I think that certainly looking at residential treatment programs if an individual is willing, and then trying some other medications is and then seeing people weekly if they're not going to go residential, and monitoring them very carefully is really, really helpful. But unfortunately, the one modality that's been shown in evidence-based contingency management has not been supported by really the government. And so very few places have a model to support contingency management. And I'd be happy to discuss that further to see. And yes, I will say that I think that it shouldn't be necessarily like an automatic removal, particularly if somebody's eligible for in-tech services. And I do think that like with a new bill that offers a pathway for these family recovery plans, there might be more options. I will offer that, like, for example, in the state of Montana, they had so many child removals for methamphetamine that eventually like the dockets were full, the court dockets, and like grandparents couldn't take in any more kids, that they eventually started having a new way to treat, and they just couldn't handle any more child removals. It was just far too many. And they started doing a lot more behavioral health and having a lot more programs available to not just the mothers, but also the fathers, so that they could keep children in the homes rather than removing all of them, because that approach just stopped working. And the judges were like, please stop. We need to find a new way to do this. So, yeah.
thank you. Another question, where can I find the Illinois policy on mandated reporting to DCFS, and what exactly has to be reported?
I mean, you can, it's easily available online, but I depending on where you work, you should have a mandated reporter, policy. I don't know, like what your specialty is, but it's an Illinois statute, and we can maybe like pull it after the webinar. So.
Thank you. And another question that we have, how do you feel about requesting a MECTOX if a UTOX comes back negative? This is if per chart review, parent has an HO using a history of using substances throughout pregnancy.
How do I feel about that? I mean, I usually go by history, so I don't necessarily, I don't order those. So that's my comment. I mean, I'm not sure, sort of like what the goal is to, I mean, I think that if we need to make a mandated report, one is able to make one based on our concern for safety of the infant in the home without necessarily a toxicology result. And that's certainly, we've done that many times. We've made those reports. We don't necessarily need a drug test to corroborate, why we think it's not safe for an infant to be discharged to that parent time of birth.
Thank you. Anyone else have any last questions for Dr. Fitzgerald? Well, once again, Dr. Rucci, we just want to give you a big thank you for being our guest speaker today and for a well informed presentation today. We appreciate it.
Thank you for having me.
Thank you. We'll just wrap up real quickly, Haley, if you can return to the slideshow, just a few more resources we'd like to share with you all. The next two resources are from the EverThrive from our organization here. The first one is this Healthy Choices, Healthy Futures perinatal education toolkit. And so this has reliable and evidence-based tools and resources to support individuals during their reproductive journeys, both before pregnancy, during pregnancy, and postpartum. Supports health and social service providers with ensuring that all people in Illinois, regardless of where they are in the reproductive journey, are able to make informed health decisions before, during, and after pregnancy. Again, a link to this toolkit will also be shared in the resources with the follow-up email. Next slide, please. And the other is our gathering campaign. So we're inviting organizations to join this campaign and share this resource. So this campaign is unique because it was really designed from a community voice perspective. And so we actually held focus groups on the south and west sides of Chicago and got input and feedback and kind of geared this toolkit to represent some of those lessons learned. And so we are just inviting everyone to access this and share this out again with their participants and their communities. It's a huge part. Sorry, I'm just spacing here for a second. But yeah, this again has more information on how to have conversations with healthcare providers and kind of to eliminate that stigma of how am I going to, how do I communicate with my provider? How do I discuss different health topics with my provider and things like that. And again, the link to the gathering will be shared in the resources. Next slide. Thank you. Again, all materials, including Dr. Fitzgerald's presentation, will be shared with everyone who registered. And then lastly, please look out for the next webinar that we're hosting on June 11th from 1 to 2. The topic and registration link are to be coming soon, but just look out for that. And there is my contact information if anyone needs it. And again, I want to thank everyone for being here today and for participating on our webinar. And I hope everyone has a good rest of their day. And thank you so much.